second lecture, which was the systemic pathologies that affect the EKG. We skipped that one so that I could get that ALS lecture in before we did the lab yesterday. So we're going to go back. So just make sure you have the lecture 2 slides up. But I did have a couple of check-on learnings from really lecture 1 that I just wanted to kind of highlight. Remember, lecture 1 was our EKG review. Okay. So our first check-on learning was which of the following is a cause of left axis deviation? And if you remember, we talked about how when you have like a axis deviation, it's usually either that side is larger than normal or the opposite side is dead. So you don't get action potential conducting through that opposite side of the heart. So you're only having vectors going in that one direction. So what are your thoughts? So it's actually Bravo. So a delta, a right bundle branch block, would actually cause a right axis deviation because you're going to have a delay in the conduction of the action potential to the right. So what's going to end up happening is you're going to have unopposed action potential conduction towards the right because the left is already depolarized and it's going to be all going towards the right. So that is why with a bundle branch block, it's going to, if you have a right bundle branch block, it's going to be a right axis deviation. If you have a left bundle branch block, it's going to be a left axis deviation. So B is actually the correct answer on this one. Our last check on learning is which of the following conditions would not be expected to have abnormally reduced the amplitude of the QRS complex on EKG? So kind of think of what would, which one of the following would not be expected? Okay, so which one would actually cause it to kind of get bigger or stay maybe normal? These not questions are kind of hard, but. So B, hypertension, because what's the hypertension going to do? It may cause left ventricular hypertrophy, which is actually going to increase your amplitude of your QRS, right? So obesity, now you have more tissue between the heart and the electrode, or the lead that it's trying to detect that. So that's going to shrink the amplitude. Chronic obstructive airway disease, kind of think of, remember when we talked about in our first block, you get that increased AP diameter with COPD, so that's going to increase that distance between the chest wall and the heart. And then a pericardial effusion, now you have like that, the detection of that action potential is going to have to go through that fluid that is present in the pericardial space. So that will shrink the amplitude of your QRS. So that leaves us with hypertension. So, okay. Recall from our first block that there were certain electrolytes that were primary or required in order to actually develop an action potential and conduct it down the pacemaker cells and through the conduction system, right? We said that was the most important ones were potassium and calcium, right? If we don't have enough of these electrolytes, or we have too much of these electrolytes, does it make sense that that's going to alter how the conduction occurs? It does, right? And so we got to know when one of our patients is experiencing an electrolyte abnormality that it's going to distort the EKG or it's going to impact it in some way. And you may be able to make your diagnosis simply by looking at the EKG and seeing these unique findings, okay? So we're going to go and we're going to talk about these different electrolytes and what those electrolyte abnormalities will do to our EKG. And we're really only going to focus, as far as the electrolytes, we're only going to focus on potassium and calcium. You notice we're not going to talk about sodium, right? Sodium is important for the myocardial reaction or function, but from a pacemaker cell and a conduction standpoint, sodium didn't really play a pivotal role in the action potential depolarization, repolarization phases, right? So Sodium is not on this list that we're going to talk about because it doesn't have a role. So let's start talking about hyperkalemia. Normal range for potassium is anywhere from 3.5 to 5.0. So that's a normal range, although it may be site-specific based on the particular test that you do. There is some wiggle room to that range, depending on if you're using a LabCorp test versus a whatever other company kind of test. So be familiar with what your facility uses and what their normal range is. And the nice thing is usually when you get the read back on the lab, it will say normal is this. So you're not having to look it up specifically. But any time the potassium level gets above 5.5, now it's going to be considered hyperkalemic, or high potassium levels. Okay? And there's lots of different causes that can lead to this, but the most common is actually a lab error. Do you have any former lab techs in here? Okay. So using a tourniquet to draw a electrolyte panel is probably one of the most common causes of it, because what happens is it causes a lysis, a breakup down of the red blood cells, which causes all that intracellular potassium to kind of get sent out to make it look like it's serum potassium, right? And that's going to cause that blood value to be through the roof, potentially. You may be thinking that this patient's about to die in front of you. I had firsthand experience of this when I was a resident. I had, a 70-year-old man who I did a routine panel of blood tests, and of course, I get the lab result back at 5 p.m., and it shows that his potassium is 6.5. And I'm freaking out. I call him, my clinic is shut down. I had called him, had to tell him to go to the emergency room. They did a lab test there without using tourniquets, and lo and behold, his potassium was actually, in fact, 3.9. So, fortunately, he was not dying at home or died on the way home from seeing me with a potassium of 6.5. It was just a lab error due to the breakdown of those red blood cells. So if you ever encounter somebody who gets a read back that doesn't make sense, just repeat the lab. And make sure you put in the order, please draw without tourniquet, and let them know what happened, because there may be some other things that that lab tech can do, or that phlebotomist can do, in order to decrease the chances of red cell lysis. But there are medical conditions that can lead to somebody having hyperkalemia. And we've got to be familiar about this, because a redraw of the lab test is not going to fix the problem, right? So chronic kidney disease, that makes sense, because if you're not filtering out high levels of potassium, then it's going to stay in the blood. Uncontrolled diabetes that leads to like a diabetic ketoacidosis is going to cause that potassium, that serum potassium, to be high. And I don't know if you talked about it in endo, but really, it's not necessarily the total potassium that's high in the body. It's just because of that acidosis, you're shifting potassium out of the cells and into the serum. And simply by correcting that acidosis, you can shift the potassium back into the cells and then ultimately lower that serum potassium levels. But the body is going to perceive that this is in fact a elevated serum potassium, and unfortunately can lead to cardiac complications. Other things, so medication problems. So when we talked about heart failure, we talked about how if you're stage C, you need to be on ACE or an ARB or an ARNI, right? That's going to cause that potassium level to go up a little bit, right? Because you have that blocking of the aldosterone system. But then also, we need to put them on an MRA. So now we've got two agents that can cause that potassium level to rise. So we got to be very careful with our cardiac patients because our medications can work synergistically and cause that value to increase and lead to cardiac arrhythmias developing. When a patient's going to or when a patient is exhibiting or has this condition, the symptoms can be pretty vague, and you may actually attribute it to other things. I mean, looking at how many diseases you've studied just this semester alone cause fatigue. How many cause palpitations? How many cause nausea or vomiting, right? These are some vague symptoms. Now, there may be some specific things like, hey, the patient's coming in with a cardiac arrhythmia. Okay, the EKG may show you that this is high potassium. Muscle paralysis. Is it maybe they've lost function because they just had a stroke? Is it muscle paralysis because their potassiums are too high? Or is there something else going on that's causing that? So none of these are like specific for this is high potassium. Okay. So you got to have a wide differential whenever you have somebody complaining of these kind of vague, non-specific kind of symptoms. But as the potassium level starts to rise, we start to see changes in our EKG. And as it gets higher, even the stereotypical EKG changes are going to change themselves. So you can kind of get a rough idea of how bad their potassium is without even drawing their blood, simply by what you see on the EKG. So for instance, when the potassium gets above 5.5, you can start to see the typical peak T waves, okay? And here's an EKG that shows an example of this. When you're looking at this, you may, if you don't look closely, you may think that this is actually your QRS, right? Kind of just maybe looks like a wide complex QRS. It looks abnormal, but that's the T wave, right? If you look at the waves immediately before that, this looks more like a typical QRS complex, right? And when we get out to our V leads, you can kind of see, okay, this looks like a typical QRS complex. This looks like a typical QRS complex, but then you got this upward, steep kind of deflection. And that is actually your T wave. It gives you that typical peakness to it. But that is when you get a serum potassium greater than 5.5. But let's now increase that potassium level. And now let's say it's above 6.5. Now you start to see that the P wave widens and flattens, the PR segment lengthens, and P waves may eventually disappear. So it may even then look like you have a junctional kind of rhythm without a P wave at all. And simply because that potassium level is rising even higher. When we get to potassium level greater than 7, you start to get this prolonged QRS interval with bizarre QRS morphology. You may start to get some blocks present to it. You're going to get this PR interval is going to lengthen, and it starts to kind of slow things down. And then potassium level greater than 9, now it develops into what looks like a sine wave, where it's very difficult to determine which is your QRS and which one is your T wave. And oh, by the way, that then puts them at an even higher risk of developing a life-threatening arrhythmia, i.e. asystole, VFib, those types of things. When you have a patient who has true hyperkalemia, the way we treat and respond to these is kind of one of four, or it's going to be 4 steps kind of to it, okay? There's 4 things that we're doing, and the mechanism of action of how these 4 steps is different. And that's why we'll do all of these kind of at once to try to lower that potassium level. So the first thing you've got to do is, if arrhythmias are our concern, or the development of a life-threatening arrhythmia is our concern, let's stabilize those cardiac membranes so we're less likely to develop that arrhythmia by giving them calcium, whether it be calcium gluconate, calcium chloride, It just depends on what you have in your crash cart. Okay. And you can see that this works pretty quick. The onset is less than 3 minutes, and it's going to last about an hour. So this is why we have that stepwise approach, because are you wanting to push calcium every hour on your patient? Oh, by the way, they have kidney disease, and they're unlikely to filter out calcium and regulate it, the levels appropriately. So you don't necessarily want to just keep hitting them with calcium every hour just to make sure they don't develop that arrhythmia. So that's why the next step in the treatment of hyperkalemia is, well, if my serum levels of potassium are too high, I need to start getting rid of it or moving it around so that it's not in the serum anymore, right? So one of the things I can do is I can then shift that potassium from the serum and put it back in the cells. So now the serum's doesn't have that elevated potassium level, and now that heart is not perceiving that hyperkalemia, even though the total amount of calcium or potassium in the body hasn't changed. The perception is that your potassium levels are not as bad as they are. And the ways that we can do this is insulin. Give them some insulin, and that will drive that potassium back into cells. But if I'm giving them insulin and they don't have diabetes and have a already high glucose level, what's that going to do to their glucose levels? It's going to drop it, right? It's going to have the same effect as if I give insulin to anybody. So it's going to drop that sugar level, and I don't want them to become hypoglycemic, so I've got to give them some glucose as well, kind of give something for the insulin to work with, right? So you'll give them a combination of IV insulin and glucose. And this is pretty fast acting, although it doesn't last, the effects don't last as long. So the concern is okay, we get to that 60 minutes after insulin. If I don't give them another dose of insulin, then that potassium can start to shift back out into serum. Another thing that I can do to drive that potassium into the cells is an albuterol, like a nebulized albuterol. And that will drive that potassium back into the cells. And then ultimately, if they're acidemic, we talked about how diabetic ketoacidosis causes that serum potassium to be high. If I have an acidotic patient, let's give them bicarb, try to bring their pH up to a more neutral level, and that will then shift the potassium into the cells. And you can see these are all pretty fast-acting things, but not as fast as the calcium gluconate, stabilizing the cardiac membranes. The third step to getting rid of that potassium, because just shifting it into the cells doesn't change the total amount of potassium in the body, right? We have, in a true hyperkalemic state, we have too much potassium in the body. So I've got to get rid of that too much and try to get it down to what it should be normally. And the way that we can do that is we get rid of it from the body. How do we get rid of toxins from our body? We pee it out or we poop it out, right? So the next steps to this is going to be, let's give them furosemide or Lasix, right? And now they're going to pee out that potassium. So now they're getting rid of that potassium from the body. And you can see the onset is pretty quick. And the reason furosemide is called Lasix is it lasts 6 hours. Okay, that's how they came up with the brand name for it. But it lasts for 6 hours. So you've got some time now to have that take effect and work to get rid of that excess potassium. So we got it peeing out, let's poop it out. So let's give them K-Exalate. Unfortunately, when you take something to get you to have a bowel movement, it typically takes some time for that to happen, right? And that's the case with K-Exalate, where if you give it to a patient, it may start to work within 2 hours, or it may be a full 24-hour period of time before they have that first bowel movement to start dumping that potassium out. Literature has also been showing that this can cause colonic necrosis, can cause perforations in the large bowel. So a lot of facilities are actually taking K-exolate off the table as a treatment option. But when you look at the literature, it does still talk about use of K-exolate in the treatment of hyperkalemia. The final way that we can remove potassium from the body is hemodialysis. Let me just hook them up to a machine, especially like if their kidneys are not working and causing it to dump the potassium. Let me hook them up to a machine that will do that job for the kidney. And the indications for hemodialysis is AEIOU, or acidosis, electrolyte abnormalities, so potassium, intoxication, so somebody trying to do an intentional overdose for suicide. We can do hemodialysis to get rid of that toxin. If they're fluid overloaded, we talked about this with our acute decompensated heart failure patients who present cold and wet, right? We talked about hemodialysis as a potential option to get rid of that fluid overload. And then the U is uremia. So those are the indications for hemodialysis. So somebody with hyperkalemia is a good candidate for hemodialysis. And then, of course, the final thing is identify the source of it. So if they're on multiple medications that cause a rise in the potassium level because of its impact on the RAS, then maybe we need to pull them off of that med, right? We did this to them. Let's fix it by modifying their medications. Okay. Or let's say they are, have pica or something like that, and they're just eating bundles and bundles of bananas, causing that potassium level to go up. Okay, maybe we need to address their dietary choices and those kinds of things. So look for the cause, and if it is a reversible cause, take care of it. So this is just kind of an illustration of the different levels of changes that you're going to see with hyperkalemia. So you've got QRS here, you've got your P wave here, and you got your peak T waves here. So it kind of gives you an idea. If we go back to when, so we said P waves will eventually disappear at 6.5 or greater than 6.5. So based on this EKG, I've got an idea that this potassium level is high because I got the peak T waves, right? So it's got to be greater than 5.5, but I still have P waves. So it's got to, probably is going to be less than 6.5 without even doing the blood test to give me that definitive value, right? But look at this EKG now. This is also hyper K. And one of the things you're going to notice is, look at, right here, look at that complex. Those look consistent, right? But then I've got this one that looks different. And oh, by the way, here as well. So I'm getting some abnormal changes to the EKG, in addition to just the normal hyperkalemia type changes. So this is somebody who could potentially progress to a life-threatening arrhythmia because of their potassium being too high. But what else am I seeing? Do I see any definitive P waves?
No.
No, I don't. So just that value alone tells me that my potassium is probably greater than 6.5. What else am I seeing? Well, my QRS is there, but I also have those peaked T waves, and you can see the QRS complexes are not normal in appearance, right? These are not narrow complex QRS waves. These are prolonged or wide complex QRS waves. So this tells me, when I look at the different values, this tells me that I'm probably in that greater than 7. And I would say that some of this could be looking like we're progressing, sorry, this one, looking like we're progressing to a sine wave, which was potassium greater than 9. So just by looking at the EKG, we can get an idea of what the potassium levels are. Yeah. Yeah, in V3 you said there. Yeah, yeah. And V3 definitely looks more like along the lines of, well, sorry, V3. So that first beat is normal. So if you look at these lined up to the rhythm strip, so this one is what we would say is the normal. But then these next couple of beats are potentially PVCs. So those are abnormal ones. And unfortunately, in that V3 lead, you're only getting that one normal-ish. It's hard to kind of see what's going on. And then you get the two abnormal beats with it. So in that case, what I would do is probably try to get a different EKG and try to capture no abnormal PVCs or whatever in that V3, so I can actually get a much better evaluation of it. But it's hard because you get two abnormals and only one normal in that snip of time. Okay. So that's hyperkalemia. What are we going to see when somebody has low potassium or hypokalemia? Sorry, going forward. So hypokalemia is typically defined when potassium levels get below 3.5. Okay, so that's going to be your cutoff. That's going to be your criteria. As that gets lower, that patient is going to be at a much higher risk of developing a fatal arrhythmia from low potassium. And some common things that can do this is diuretics. So we did this to them with the furosemide that they're on while I'm trying to diurese them from their heart failure exacerbation, right? It's one of the reasons why we regularly will check our electrolytes on our patients who are admitted to the hospital, and we're giving medications, giving treatments that could affect the electrolyte levels. Excessive diarrhea can cause you to poop it out. Remember, one of the treatments for hyperkalemia is Kayexalate to get you to get rid of it with stool. Well, let's say you have somebody who has norovirus, as the Navy likes to call it, double dragon, because it comes out explosive both ends, oftentimes at the same time. But you're going to be dumping potassium along with it, right? But what if you have somebody who is trying to lose weight, i.e. our active duty folks trying to make weight, and they are abusing laxatives? How is that going to affect the potassium levels? So you have a young active duty person come in who is not on any other medications that typically would cause them to lose potassium, and they're coming in with an arrhythmia associated with low potassium. Maybe look at the supplements that they're taking that they weren't prescribed, because maybe they're doing something inappropriate with over-the-counter meds. Refeeding syndrome is another cause. So, anybody ever seen Band of Brothers? The episode where they liberate the concentration camp, and initially they're giving all the food out to the Jewish folks in the concentration camp, and then they have to stop giving it and take all that food back. The reason was because of refeeding syndrome. When you're in such a nutritional deficient state, processes shut down. When I start to give nutrients back, systems start to come back online that start to use electrolytes and all these other things, and in an indiscriminate fashion, and the body can't keep up with that, and you'll see electrolytes just dropping. I had a patient during residency. He was an OIF, OEF, double amputee who was a chronic alcoholic. His calories for the day was only alcohol. Bring him in. Of course, he's not getting alcohol in the hospital. We're trying to treat his alcohol withdrawals, but he then goes into refeeding syndrome, and now we are struggling to keep his potassium up, we are struggling to keep his magnesium up, and we struggle to keep his phosphates up. So we had 2 peripheral IVs because we were on the regular floor. The ICU was like, well, he's not bad enough to be down here to get a central line to do this. So we were struggling trying to get potassium and magnesium and phosphates or phosphorus in to try to keep it up. It seemed like it was just around the clock. He was getting something. When that bag was done, then he was getting phosphorus. When that one was done, he was getting magnesium. So it was very challenging to treat the refeeding syndrome that he was experiencing. And it wasn't like we gave him a Thanksgiving feast. We just gave him a bowl of cereal. And it tricked this. So eating disorders can cause this. And then the other typical things that we may have talked about, so hyperaldosteronism, when we talk about hypertension, right? That causes the potassium levels to drop. That can lead to it, and then some of the other types of diseases. But the way a patient is going to present to you with hypokalemia is going to be, again, kind of vague-ish kind of symptoms. I'm malaised, I'm weak, I've got cramps, I've got some numbness and tingling, okay, rhabdo, okay, that's probably significant. But these are kind of vague type of symptoms. Now, hyporeflexia can be a symptom associated with it, or a finding associated with this. So that maybe is a little more unique. But there's other things that can cause hyporeflexia as well. Oh, and by the way, it can also be arrhythmia. How many things can cause arrhythmia? So again, to keep that suspicion broad when you're encountering your patients, and get the labs to prove or disprove what's going on. So we said hypokalemia is less than 3.5, but what happens, let's get into the severe hypokalemia range, and say that now that potassium level drops below 2.7. With this, I am going to see some significant changes to my EKG. So I'm going to get an increased amplitude and width of the P wave, so you can kind of see here. Almost looks like I have a peaked P wave. I may get T wave flattening or inverted even. That does look normal here, so I wouldn't be concerned about that. I may get ST depressions. Don't really see that on this one. Appearance of prominent U waves. So I've got the little arrow sign, but that's showing you got these little things, and these are consistent after your T wave. Those are actually U waves. Something you'll see with hypokalemia. But what happens if those U waves were to occur a little earlier than this example shows? Now you're actually getting a fusion of that T wave and that U wave, and it may make it look like that T wave is kind of prolonging out, simply because that extra wave is being buried into that T wave. So what's going to happen? Why are we concerned about somebody with hypokalemia, especially severe hypokalemia? Well, it can develop into a life-threatening arrhythmia. And you look at this list, okay, yes, you can survive with these things, right? Although if you have a fast heart rate, maybe that's going to contribute to morbidity and mortality, right? We do things to treat these conditions, but as we talked about yesterday, VTAC can lead to pulseless VTAC, VFib, not compatible with life, and then even going into torsades, which can lead into a life-threatening arrhythmia. Here's just another EKG example showing you prominent U waves, and you can see here, like this looks like a double T, right? This is your U wave. And you can see it doesn't let your T wave get down to baseline before that U wave starts. So again, imagine those beats or those waves are starting to fuse, and that could cause a prolonged T wave, or what would look like a prolonged T wave. So how are you going to treat these patients? If I have low potassium, Does it make sense that I gotta give them potassium, right? Do I also need to maybe adjust their medications if they're on something that causes them to get rid of potassium? And the answer is yes to that, right? The problem is oral potassium, if you have 10 milliequivalents of potassium, I expect it to go up 0.1. So if I'm at 2.5 and I'm trying to get it up to 4.0, but I can only give you 10 milliequivalents an hour, that's going to take 15 hours to get you back up, right? So it's going to take a long time for that to happen with oral potassium. Intravenous potassium, yes, I am going to raise that potassium level a lot faster, but if I have a peripheral IV line, it burns like hell. So I have to have an infusion rate that is so slow that it's going to take hours and hours and hours to get the potassium up to a normalish level. So a lot of times if you're having to do potassium infusions, they have to go down to the ICU to get a central line placed, and then they infuse through the central line, because they can infuse it at a much higher rate because they're not having that burning sensation of the potassium going through the peripheral IV. So you're going to be limited on how quickly you can get that potassium level up. When you do have somebody with hypokalemia, look at the other electrolytes to include magnesium. Your basic metabolic panel does not test for magnesium, so you're going to have to do an additional order for magnesium or an additional order for phosphate to look at those values to see if those are abnormal as well. Here's just kind of a summarization of the different EKG findings you're going to see at different values of your potassium. Okay, this is kind of like a summarization slide and also a visual representation of those changes. So it's a good review slide. Another way to remember is if you use the Dr. Dubin thing, a hyperkalemia is like somebody grabbing onto the T wave and pulling it up like a tent, and you're packing in all that potassium underneath that T wave. If it is hypokalemia, it's like they're pushing down on the tent because you don't have the potassium to fill up underneath the tent. So that's what you would see on the EKG with potassium abnormalities. Let's look at the calcium though. We said potassium and calcium are important for depolarization, repolarization of the cardiac pacemaker cells, the conduction system. Let's look at what calcium is going to do to our patient's EKGs and what a deficiency or an excess of calcium is going to do to this patient. So hypercalcemia is defined as a calcium level greater than 10.5. Normal is from 8 to 10.5. And this can also be a life-threatening emergency. But the common causes for this, think of things that regulate the calcium levels in your blood. And now let's think of systems or processes that change that normal control. So I've got a malignancy like lung, breast, or multiple myeloma, where now I'm breaking down bone and releasing calcium from bone. Or maybe it's a syndrome of inappropriate secretion of hormones, and maybe it's like producing like kind of makes it look like a hyperparathyroid state, right? Now I'm causing an excess absorption of calcium out of the intestines, and I'm not regulating that appropriately. Immobilization can do that because you start getting breakdown in calcium release. Kidney failure because you can't regulate, or you're not regulating the values, so you're not secreting calcium when you should, and those kind of things. Hyperthyroidism can do that, and then thiazide diuretics can cause the calcium levels to increase. So what are the symptoms going to be? Fortunately, there's a little saying that kind of helps you. So bones, stones, groans, moans, groans, and psychiatric overtones. So the owns are the symptoms you're going to see. So bones, well, you're going to have abnormal bone remodeling, or they're going to have fractures. Okay? So yes, elderly females at risk for osteoporosis, they fracture a bone just by simply sneezing hard, right? But let's say we have a patient who's in their 40s who shouldn't be somebody with advanced osteoporosis, who, you know, did something minor injury and then a major bone fractures from this. Maybe I should suspect something going on with their calcium levels. Because I have all that extra calcium, I got to get rid of it, right? So I start to secrete it, and that can lead to kidney stones. The most common form of kidney stones is calcium oxalate, right? Groans can cause abdominal cramping, pancreatitis, just not feeling, the GI tract is not very happy with elevated calcium. Moans is just fatigue and malaise. Groans is polyuria, polydipsia, and constipation, so you're always on the toilet. And then psychiatric overtones, so they can have altered mental status, psychoses, those types of things those symptoms are caused by that calcium level being elevated. So what are you going to see on EKG? Typically, the main thing you're going to see is just the shortening of the QT interval. If I have a hyper, things are going to speed up. So let me just shrink that QT interval. But I can also start to develop this thing called a J-wave. J-wave or Osborn waves, where instead of having that J-point deflection that leads into my ST segment, I've got then a little extra uptick kind of thing, and that is called a J-wave or an Osborn wave. And we'll talk about another condition in a few slides that also has this finding that has nothing to do with calcium. But this is just an EKG example of a J-wave. It almost looks like a delta wave, but just on the other side of the QRS complex, right? Would you agree with that? But that is a J-wave. Here's an example of an EKG that shows that shortened QT interval. So that QT interval is shortened, and that is because of the hypercalcemia. That repolarization occurs quicker than normal. The way you treat a hypercalcemic patient is the solution to pollution is dilution. So when you give them IV fluids that don't have calcium in them, so don't give them lactated ringers, okay? Give them normal saline. Normal saline has sodium and chloride and water. That's it. So be careful of what you choose, or be careful of that IV fluid that you choose, so you're not making the situation worse. So, but give them IV hydration. Try to dilute that a little bit. Maybe you can bring that value down closer to 10.5, or bring it down to 10.5. I can then also give them anti-resorbative agents. So, like in a condition where bone breakdown is causing that calcium level to be elevated, maybe I need to give them a medication to, instead of breaking down bone, let me build bone and take that calcium out and utilize it to make hardened bones. So what can we do? So our bisphosphonates that we typically will give to our osteoporotic patients, right? That will give them that, the whole point of that is to try to build that bone up and make it stronger. So maybe let me give them something to help put that in. Calcitonin is also something that's going to lead to building of bone, right? So maybe let me give them some calcitonin. Unfortunately, these are not going to be very quick. Calcitonin, okay, maybe we might get a reduction in 12 to 48 hours, but the bisphosphonates is going to take a couple of days before you really see any change in the value of your calcium. So it's going to take a while. The other thing would be, okay, if we can't dilute it out, let's get rid of it by peeing it out. And so you can give them pyrosamine, cause them to dump calcium into the urine. You get rid of it. Okay, we got about 3 minutes before our break, so we'll go through hypocalcemia and then take our break. So hypercalcemia causes things to speed up, shortens the QT interval. Now let's do the opposite. Let's look at hypocalcemia, which is defined when that value of calcium gets to less than 8.5. And this can lead to all kinds of different arrhythmias. And the things that we typically think of that cause this is a problem with the regulation of that calcium level. So your parathyroids are supposed to regulate your calcium levels in your serum. Well, if I have hypoparathyroidism, I'm not secreting parathyroid hormone, that's going to lead to my calcium levels dropping. So I'm not absorbing and utilizing calcium properly anymore. Vitamin D deficiency is important for the absorption of calcium, right? That's why a lot of times our calcium supplements are a combination of calcium and vitamin D because you can absorb it better. So vitamin D deficiency, and this would be like a severe vitamin D deficiency. This is not your, oh, normal is greater than 30, oh, I'm 29, I'm at risk of hypocalcium. No, it could be like that person who's got a value of like 5 to 10 at risk of this. Okay. And then renal failure, just because you lose control and the ability to regulate values. Looking at the EKG, remember hypercalcemia causes things to speed up. Well, hypocalcemia is probably going to cause things to slow down. And you see that where you start to get a prolonging now of your QT interval. So we get this prolonging. And you can see a couple examples where it's like, okay, this QT interval does not look right. Should be right here. Sorry. Does not look right. Well, let's see. Is it? So normal QT interval should be less than 1/2 of the R to R distance, right? So my top line here is your R to R distance. I put a little halfway mark, although it looks like it might be shifted over a little bit, but just say that's the halfway mark. Now I put another line on my QT interval. Let me move that up, and lo and behold, we are greater than 1/2 that R to R distance. So this confirms that we have a prolonged QT interval. And then this is just, again, a summarization slide of the different changes on your EKG you're going to see with hyper and hypocalcemia. So this QT interval is shortened, and, sorry, right there, hypercalcemia, this is what it should be, and then this is a prolonging of that QT interval. And the way you treat it is, if I have low calcium, I'm going to give them calcium. So you can give them calcium gluconate, you can give them calcium carbonate for like in the acute setting. But if I need to give them something chronically, then I can give them calcium supplements, oral supplements, typically in combination with vitamin D, so I am absorbing and actually utilizing that calcium that I'm taking, right? If you have a patient who can't swallow pills, so like a pediatric patient, your alternative is Tums, calcium carbonate, right? So I had a pediatric patient when I was doing inpatient peds who had hypoparathyroidism. She couldn't swallow pills, especially since the calcium vitamin D pills tend to be quite large. She couldn't swallow them, so we were giving her Tums. And her prescription was eat 4 Tums every 6 hours. And that's what she was doing to try to get her calcium levels back up to normal. So. And then ultimately, of course, let's treat the underlying disease and cause of this, and treat the hypoparathyroidism or the vitamin D deficiency appropriately, and that should help restore that regulation that you need for your calcium levels. So let's go ahead and take 10 minutes. We'll come back to this. from a career advice standpoint, make friends with folks because you never know what's going to happen in the future. So a friend of mine from when I first was a flight doc is now in a senior leadership position in the Navy for the residency in aerospace medicine specialty. And his job is to make sure all of the carriers have people assigned to them. And unfortunately, there's not enough of them to do that. And he thought of me, and I now am going to have orders to the John F. Kennedy to be their senior medical officer. So it's pretty exciting, but not something I thought I was qualified for, but pretty exciting. Although I don't have any idea what I'm going to detach yet from here. I was hoping to stay here, but the Navy has bigger things in store for me. So it's the newest aircraft carrier that's still being built. So I'll be reporting up to Norfolk, and then I'll be responsible for running the medical department to get us fully operational online, so that we can put 4 heads on 4 heads with the newest Ford class carrier. So pretty excited. There's 5,000 people on board, so it's a lot to take care of. And you also are responsible for all the small ships around too, as the kind of referral center. So all our destroyers and cruisers, they just have independent duty foremen, they don't even have PAs on them. And they would fly casualties or medical cases to the carrier to get stuff taken care of. So kind of interesting. Although I will say I became so specialized in carrier aviation that I was really the only one of the few people in the Navy who could fill this spot. So maybe it's voluntold kind of thing. But I was a flight doc, which they need, and I would have carrier deployment experience, and I'm a senior physician. So yeah, there's probably 2 of us in the Navy that fit that bill. So
what's your path look like on the ship?
Yeah, so on a carrier, so we are not a casualty receiving ship on the carrier like our large deck amphibs. So like the large deck amphibs, once they put their Marines ashore, then they stay on station ready to start taking casualties back from those Marines who were pushed on shore. So they can do either the hovercraft come on board to bring the casualties back, or Ospreys, other helicopters, and those types of things. The carrier's mission is really just warheads and foreheads. So, but because we have so many, and because the flight deck is the most dangerous environment you can work on, and trauma is a concern, in addition to the senior medical officer, you'll have another family physician, you'll have a PA, you'll have 1 or 2 independent duty corpsmen as your kind of your main primary care kind of providers. Then you have a general surgeon that do trauma. You have either a nurse anesthetist or an anesthesiologist to be able to put people to sleep. And then you have a critical care nurse, so you can manage. You got like a 2-bed ICU or something like that on the carrier. And then with corpsmen, there's about 50, I think, corpsmen attached to the medical department. And then when the air wing comes on board, they bring another 7 or 8 corpsmen with them. So, and then 2 flight docs, so or an aviation PA. So, so yeah, you get plus stuff. So it's pretty big hospital system. But exciting, but that means that I have to leave you guys. I don't know when. Hopefully after you guys graduate. But all right. So let's continue with our lecture. So we talked about pericarditis already. Okay. So we'll probably get through this section pretty quickly. But with pericarditis, you can diagnose pericarditis with the typical EKG findings even before you do any other tests, right? So we talked about pericarditis before. You know, you get this positional kind of chest pain. It's worse with laying down, coughing, improves with like leaning forward, right? But then on the EKG, we say that there's a widespread ST segment changes. It doesn't localize to a specific coronary artery distribution, right? And then you tend to also have some PR depression on your EKG. But the other thing that you can see with it is you get a widespread concave ST elevation, and I'm going to show you what that looks like on the next slide. And you tend to get reciprocal ST depressions and PR elevations in lead AVR and plus or minus 1. Although the most common thing you're going to find on your EKG is just sinus tach. So this is what you're going to see. This is that concave ST segment elevation. Kind of think of it, it looks like a smile, right? So this tells you that it's not it's less likely to be a concerning ST elevation caused by a STEMI. You can see that smile along with the different leads, especially in the V5, V6 area. And then we talked about reciprocal changes in AVR. Here's our PR kind of elevation and our ST depression in lead AVR. And you can kind of see that. Here's a good example of that. Here's that that finding that we talked about with that ST depression. We talked about that concave in V5, V6 area, ST segment elevation. And you can see it's kind of across. So you definitely have ST elevations in V4, 5, 6, V3, V2. When you're looking over here, okay, 1 has it, 2 has it. So you're like, okay, then this is not left anterior descending or circumflex. But 3, although that looks like it could be normal size, but you can see it's not localized to a specific coronary artery distribution. So how do we treat pericarditis? We talked about it in block 1. So we're going to use like our NSAIDs and colchicine. However, if they had a heart attack recently, and this is a post-MI pericarditis, you don't want to use an NSAID. You don't want to use steroid. You just want to use aspirin and colchicine because the NSAID and the steroid could interfere with scar formation of the infarcted area and put that patient at risk of having a ventricular wall rupture and lead to hemorrhage out of that. So aspirin and colchicine in the setting of post-MI pericarditis. Next condition is cardiac tamponade. Again, we talked about that in block 1 as well. Lots of things can cause this. We typically think of it as like traumatic, like a trauma, and then they have this significant bleeding into the pericardial space leading to this cardiac tamponade. We talked about Beck's triad, right? Muffled heart sounds, JVD, and hypotension. But what you're going to see, or can see on somebody with a pericardial effusion / cardiac tamponade, is this electrical alternans. So the amplitude of the QRS is different from beat to beat. So look at this amplitude here. Okay, the next one's larger than that, and then this one's the same. Then it's larger, same, larger. And just think of this as the heart is kind of moving back and forth between or within that excess fluid around the heart. And so that's going to cause it, this beat, to be closer to the lead, and then the next beat it's swinging away, and now it's farther away, and then it swings closer again and everything. So electrical alternans is what you're going to see with cardiac tamponade. And the way we treat it, of course, is going to be to drain it. Let's get rid of that fluid, and you can do that under ultrasound guidance. You can do what's called a rush echo, rapid ultrasound for shock and hypotension, to be able to diagnose that there is an excess fluid around the heart, and then also help you with placing the needle to start to drain that fluid. And there's a couple of different approaches that you can use. Not important for our class, maybe more important once you go to EMED next semester, but there's lots of different approaches to treating them. Okay, next condition we got to talk about is pulmonary embolism. So I know this is not pulm, and I know you got your test on Monday for pulm, right? Pulmonary embolisms Yes, blood clot gets up into the pulmonary arterial system, it blocks the blood flow, and that can lead to shortness of breath, chest pain, and may even lead to respiratory distress. But ultimately, what you're going to see on your EKG is actually maybe some non-specific things like sinus tachycardia as being kind of like the most common or one of the most common things seen on your EKG, and that's not specific to anything. But one of the classic kind of things that you're going to be tested on your standardized tests associated with PE is this S1Q3T3 finding. Okay, and the reason you see this is it really comes down to right heart strain. Okay, that's why it says it's signs of acute cor pulmonale or evidence of strain. And what you're going to see is on your EKG, you're going to have a S wave in lead 1, and you can see that on this example right here. You're going to have a Q wave in lead 3 that you see right there. And then you're going to have an inverted T wave in lead 3 as well. So S1Q3T3 is the classic testable EKG finding you're going to have for PE. But when we go back a slide and I show you the kind of the incidence of these findings on your EKG when somebody has a PE, you can see 1 in 5 people with a PE are going to have that classic finding. And it really just kind of depends on how severe, how big, how bad is that PE, and is that causing right heart strain. So it really just kind of comes down to that, right? Here's an example of a patient with pulmonary embolism. And you can see a couple of different things. So we got a right axis deviation with a right bundle branch block. It's got the deep S in lead 1. So look at this S wave here. You've got a Q wave in 3. So it's kind of weird looking. Oh, sorry, here's 3. So here's your Q wave. And you have an inverted T wave in lead 3 as well. Inverted, inverted. What's interesting is there's no tachycardia to this, but yeah, maybe they're on a beta blocker that's controlling that or whatever. But you see this S1Q3T3 finding on this EKG. And the way you treat it is, of course, dependent on how severe their condition is, how severe their presentation is. It could be, I just need to get an anticoagulation and let the body's own blood clot busting mechanisms kick in to get rid of that clot. Or I may need to be a little more aggressive and do fibrinolytic therapy, so give them TPA to break that clot up. Or maybe I need to go in and be even more aggressive and do procedures to go in and remove that clot surgically or via a procedure. Okay, next condition, next abnormality on EKG is a low voltage EKG, which is defined by having a QRS of less than 5 millimeters in your leads 1, 2, 3, ABR, ABL, ABF, and then less than 10 millimeters in your chest leads. So if you just look and you're like, wow, all these QRSs are smaller than normal, see how big they are and see if they meet that criteria. And things that can cause this, think of things that, like infiltrative diseases, so we talked about like amyloidosis, sarcoidosis in like a constrictive, constrictive pericarditis or restrictive cardiomyopathy, right? So it could be that. It could be a pericardial effusion, which we also talked about how you can have that alternans, electrical alternans with pericardial effusions. You could have COPD or obesity where it's causing that increased distance of the lead to the heart. So it's just proceeding because it has to transit farther. That amplitude tends to be smaller. And then here is an example of that. And you can look at the amplitudes of your QRSs are quite small. Okay, told you we'd roll through that quickly. Our next condition is hypothermia. And think of it as, if I'm hypothermic, things are shutting down, right? Things become slower. I move slower, right? Think about when you were in the classroom earlier this week before they kicked the heat on, and it was freezing cold. You were moving and thinking slower. Same thing goes with your EKG and your cardiac function with hypothermia. And hypothermia is not a 97.1. It's actually getting less than 95 degrees Fahrenheit. Okay. And typically what you're going to start to see is, okay, a bradyarrhythmia, things are slowing down. Osborn waves, we talked about Osborn waves or J waves with hypercalcemia. We can see those in hypothermia. Things are slowing down, so I'm prolonging my PR, I'm prolonging my QRS, and I'm prolonging my QT interval. So the whole thing starts to prolong because, again, I'm slowing down my body processes and everything like that. But if I start to slow things down too much, then my other pacemaker cells may feel like they've got to pick up the slack. So I might start to develop ventricular ectopic beats because it's just getting too slow, and now that internal pacing rate of this ventricular tissue is then going to kick in and cause a beat. And the concern with that would be, well, what if that starts to take control of your overall rhythm? That can lead to an arrhythmia, like VTAC, pulseless VTAC, VFib, or even asystole. And again, just looking at Osborn waves, or the J waves being present in hypothermia. So how are we going to treat it? Well, kind of think of this as, we already did the ALS lecture. So one of the H's and T's that you have to consider when you're dealing with a cardiac arrest patient is hypothermia, right? So let's start to warm them up. You're going to do all the other things to manage the arrhythmia that you're presented. So if it's pulseless VTAC or it's VFib, you're going to be doing your, you're going to be doing your epi and your shocking, right? If it's asystole or PEA, you're going to be just doing your epi and CPR, of course, right? But you got to think about this patient's in this presentation because they are cold. They cannot be dead until they are warm and dead, right? You've got to warm them up. And a couple of ways that we can warm them up is either a passive rewarming, which would be like taking off cold, wet clothes, putting warm blankets on. You can also do active external rewarming, which is like putting on a bear hugger. I don't know if you've seen that before in like an operating room. It's kind of a like a little sheet that has an import thing into it, and you blow hot air into it, and kind of now serves as like a blanket, a heated blanket for the patient. Or we can do active core rewarming, which would be giving warmed IV fluids. It could be instilling rectally warm fluids, and then they come out and you put more warm fluid in and it just kind of circulates in and out. And you also then do that from above as well. So you're a lot more invasive in the process of trying to warm that patient up. But you got to warm them because they cannot be declared dead until they are warm and dead. Next thing we're going to look at is cocaine and amphetamine overdosing. So cocaine and amphetamines, they inhibit the norepinephrine reuptake, and they increase the sympathomimetic effects. So think of this as your sympathetic nervous system is in overdrive because of the effects of this medication. And you lose control of the regulation of your heart rate if you have a drug that's causing a reaction like it does with cocaine and amphetamines. And so what you might end up seeing with this is myocardial ischemia infarction, just because you can't, that supply cannot keep up with that demand. or you may see like myocarditis or like an inflammatory kind of reaction. So.
What's the word actually doing during the portion? Why is it
Good question. I don't know the answer actually to that. I'll have to look that up. Other things you might see on the EKG would be like widening of the QRS and QT prolongation. And that has to do with the effects of cocaine and amphetamine on the sodium channels. So you may see that. But here's an example of somebody who is in a cocaine intoxic state. You see one very sinus tacky looking, right? And then you see a widening of the QRS complex and QT prolongation there as well. This person's also going to be probably pretty agitated and screaming at you because they are on too much cocaine. Amphetamines, in addition to those other things that we saw with cocaine, you may also get that QT prolongation as well. And ultimately, when you do have a patient who has cocaine and amphetamine toxicity that you're seeing coming in with this arrhythmia, normally we would think about, well, let's slow down the heart rate by pushing beta blockers, right? You don't want to do that in these patients because you can get that unopposed alpha that then causes the blood pressure to drastically go up. So really think of the treatment, first line treatment for somebody coming in with cocaine and amphetamine toxicity is benzos. Give them benzos, calm down the system first, and then step in, okay? But the biggest thing is don't do beta blockers for these patients. You can do calcium channel blockers. You can use that because you don't get that unopposed alpha and the effects of the blood pressure with calcium channel blockers, but don't give them beta blockers. Now, I wanted to finish this lecture talking about Brugada syndrome, because this is something that you may encounter in your practice, and this is something that's going to affect your young active duty population, okay? And the reason we talk about this is because, yeah, maybe it's not very common, 3 to 5 people out of 10,000 have it, more common in your males who have Southeast Asian descent. But the age that this affects is your active duty, and 4% of all sudden cardiac deaths are caused from Brugada syndrome. There may be a genetic component to it. About 28% of cases of Brugada, there's some kind of autosomal dominant thing. We don't truly understand why this happens, but we think it's because of some sodium channel mutation that leads to changes like the depolarization that leads to this. And your patients, if they have Brugada syndrome, the vast majority of them are just going to be asymptomatic and potentially think of them as like ticking time bombs. Because they could just be enjoying their life and then all of a sudden, cardiac arrest, and they just drop. And now they, now they're dead. So, it could be that's how they're going to present to you. Now, it could be that they give you some warning signs. A 20-year-old, a 30-year-old should just not have a syncopal episode, right? That's why when we talked about syncope at the end of block 3, we talked about a lot of these folks are admitted to the hospital because cardiac disease is one of the more common causes of syncope, a true syncope. They may also have non-specific symptoms of palpitations, they may have dizziness and those types of things. But what you're going to see on your EKG, if you're looking at like V1, V2, and even V3, there's three patterns to this. So type 1, you're going to have this what's called a coved ST elevation that's greater than 2 millimeters. That's accompanied with inverted T waves of V1, V3. So that coving is this little thing right here. Okay, that's type 1 Brugada. That then leads into that inverted T wave. But you see that that's an ST elevation, right? You may be concerned that this person's having a STEMI, septal or anterior STEMI, right? Based on that ST elevation. But there's just a unique little look to it that gives you this Brugada syndrome, or this Brugada appearance. Type 2 is this saddleback shaped, where you have an ST elevation of greater than 2 millimeters in V1 through V3. So when you look at, okay, V1, this is not a great look of it, but when you look at V2, it looks like a saddle. Somebody could sit in that, right? But that's that ST elevation, and it's greater than 2 millimeters. And that's important to note that greater than 2 millimeters, because when you look at a type 3, you still have the same appearance, but that ST elevation is less than 2 millimeters. So just basically think of it as type 3 as a type 2, but just less severe, less of a ST elevation. And this is an example of that here. This ST elevation, giving you that saddleback appearance, but less than 2 millimeters. Looks like maybe only about a millimeter, and that's it. So why are we concerned about this? Well, they are at an increased risk of sudden cardiac death in a younger person, not a person who should be considered at risk of having this happen to them. And a lot of times they are asymptomatic and have no idea what is going on. If the problem is development of a life-threatening, sudden onset of a life-threatening arrhythmia, does it make sense then that maybe we need to place an ICD, especially if they're symptomatic, to shock the heart if it were to develop one of these arrhythmias from this? So that's in a symptomatic person, we're going to do an ICD. Now there are some emerging evidences, and this is just kind of, we'll see in the next 5-10 years what changes, but there is some radiofrequency ablation type stuff that they can do. Quinidine actually can be used as an adjunct to control this, but typically we use this for those people who, even though they have the ICD in place, it is frequently shocking them because they're frequently are going into this arrhythmia. Maybe we can give them quinidine to kind of prevent that from happening in the first place. But if the patient is asymptomatic and you just did a routine EKG that just diagnosed them with Brugada, but they've never had syncopal episodes or pre-syncopal episodes, they don't have dizziness, they don't have palpitations, then the treatment is actually not as clear cut. There's a lot of argument in the literature on, do we just let them be, or do we need to put an ICD in place? And unfortunately, just because they're not symptomatic at this moment does not mean 6 months from now they're going to be asymptomatic. It could be that they develop sudden cardiac death 6 months from now. But I talk about this because this was a case actually from the ship I was on before, coming here, where I had a 29-year-old active duty E6 who came up. He had a known history of anxiety disorder. He was already seeing mental health for his anxiety, who came up to ship's medical and said, hey, I had chest pain earlier today. It's not there now, but I did have it earlier. I just want to get checked out. I'm off my watch. I want to get it checked out. So my LPO, my lead petty officer, so NCO, lead NCO for those in the Army and the Air Force, he did due diligence and he went and got an EKG. And the EKG, he brings it to me, he's like, sir, I think you need to take a look at this right away. The EKG computer read said STEMI, because he had ST elevations in V1 through V2 of at least 3 millimeters, and in V3 it was 2 millimeters. So elevated, right? This is either a STEMI or Brugada syndrome, right? I go in, I start evaluating him. He's not having any chest pain symptoms, so I don't necessarily give him nitro at that point. But I'm also like, I don't want you on board my ship right now. We're calling the ambulance and getting you off the ship into the ER. Now, when they got to the ER, the EKG and the ER actually showed the typical code appearance, so like the type 1, and their computer read said Brugada. Unfortunately, we did not have a cardiologist on the entire island of Guam at the time. because we don't have a military one. And in the civilian sector, we had a cardiologist who would fly in I think from Japan, who would see a bunch of patients for a month, and then he'd fly off and come back in 3 months when it's time to follow up with all those patients. And then he'd fly off and come back in 3 months. So we did not have a cardiologist on the island at all to review this case and manage this case. He was in the hospital. He remained stable. Didn't have a recurrence of his chest pain. But the history that we got at the time was, yeah, you know, I've had a couple of episodes where I almost felt like I passed out. Well, that's concerning. We just talked about Brugada syndrome. That seems concerning that he is symptomatic. I definitely did not want to keep him on the island. And oh, by the way, he was about to transfer. The movers had already come up and picked up all of his stuff, and they were sending it to Great Lakes Naval Station, which is where the Navy does all their enlisted training. And he was going to be a drill instructor. Not somebody who I want PTing hours and hours a day, right? So we send him to San Diego, and found out last semester, OC Scarlett with the current senior class actually was on the receiving end of this patient. He went and saw a electrophysiologist cardiologist, who initially was like, okay, this sounds normal, not concerned. Doesn't sound like you're having symptoms, because the history he got was he did not have any syncopal episodes or pre-syncopal episodes. So the history kind of changed from what we got and what the cardiologist got. But he offered him the opportunity to do an EP study just to make sure. And so they did an EP study, and he went into VFib. Like, shocked his heart, got him back into a normal rhythm, and the next day he had an ICD placed. 29-year-old E6 active duty, now with an ICD in place. Med warning. Out. The frustrating thing was MEPS stopped doing EKGs right before he went through MEPS. So this is something that we could have diagnosed and seen long before he joined the Navy. But because we stopped doing a basic test at the MEPS facilities, we had no idea what his baseline EKG was. And we didn't know that he had this condition that could have caused an acute cardiac death. So imagine being forward deployed, imagine being on the lines, and all of a sudden one of your guys just drops. So, and he fit the normal thing. He was Southeast Asian descent, male, and he was 29, so kind of the average age is 41. So yeah, so he kind of fit the bill for somebody who could have problems related to his Brugada syndrome. But fortunately, he had a good ending as far as it wasn't that he was dead. So at least my lecture is not ending on a sad note for once. But it's something that we got to be careful of and aware of, because your young, healthy, physically fit, active duty member that you're going to take care of could be having this condition. So, questions about anything in this class or the test or anything like that? We will have a makeup next week at some point to do our review. I don't know the exact date. Dr. Choney didn't tell me when I had to move yesterday's class around. But at some point, when you see the new calendar come out, there'll probably be another cardio lecture block next week so that we can do a review for this. And then, of course, following Monday is our test together. So, all right, enjoy the weekend.